Well, good evening and welcome to another edition of Question Lab. I am your host, Jeff, and tonight we are going to lead you through a set of USMLE-style questions based on pathology. That's our topic tonight. To help lead you through it, you're going to be guided by the one and only Dr. Paras Vicaria. Paras, would you like to introduce yourself to the crowd?
Thank you, Jeff. Yep, absolutely. Hey guys, my name is Paras. I'm a dermatology resident here in Dallas, Texas. I originally graduated from pharmacy school and then went on further to do medical school. I'm also an RX coach with USMLE-Rx, so I work one-on-one with students such as yourselves to help prepare you all for USMLE Step 1 and Step 2 CK as well. And I'm happy to help lead tonight's session.
And get started. And we're going to start with question one. And the thing to keep in mind here is that as we reveal the questions, you're going to see a couple things that are a little bit different. First, you don't see any answer options, okay? And that's part of our approach. We prefer that you cover up those answer options when you when you look at a question, because we don't want you to see something within the those answer choices that maybe you don't recognize or that you feel like you don't know. It's the kind of thing where you can kind of get panicked even before you're digging into it. So we say train your focus on the question. So we ask you to read that lead in first. And the lead-in is the actual question part of a USMLE item. So in this case, the lead-in is which of the following is a characteristic of the most likely prescribed medication. So we ask you read that question, look at it, and kind of think about what kind of information you might be looking for. So you know that there's a medication involved. And that you're going to be looking for some clues that are going to help you solve it. So after you've read the lead in, now read the vignette. A 63-year-old man comes to the emergency department with a 2-day history of palpitations. He is found to be in atrial fibrillation and has begun on medication to prevent the formation of atrial thrombi. 5 days later, he develops painful lesions on his left shoulder, as shown. So that's the image there. So again, the question, which of the following is a characteristic of the most likely prescribed medication? And I want you to think, how many steps do you think it will take to solve this question? Go ahead and put that in the question box. Let us know what you're thinking. Is this a 1-step, 2-step, 3-step question? As we turn it over to Paras to help break it down. Paras?
Thank you, Jeff. So what we're going to do is we're going to go ahead and show you what we think are the important clues in this lead-in and the vignette. And so what we're going to do is first off start with the clinical situation. So we've got a 63-year-old that's generally what they're going to do. And we've got a patient who's coming in because of palpitations. And a lot of times then they'll tell you how long it's been going on for. So the chronicity, 2 days, 2 months, 2 years, and that kind of gives you a sense of, is this more of an acute picture or a chronic picture? In this case, we're told that he has a history, he is found to be an AFib, and he started on a specific medication. And then they give us a picture of some painful lesions he developed. So obviously, these are all important things that we want to make note of because they're asking us about a characteristic of the most likely prescribed medication. So in this question, we've got a couple things to figure out. Got to figure out what's going on in this patient. 2, what medication may have caused that. And 3, what is a characteristic of that medication? So maybe a 3-step question here. So what we're going to do is we're going to go ahead and open up those answer choices. And what we're going to do is we're going to start at the bottom and we're going to work our way up to the top. Answer choice E, low platelet count. D, its effects are reversed by aminocaproic acid. C, increased prothrombin time. B, direct inhibition of thrombin. And A, development of IgG antibodies. And one of the things is, when we work with students, we actually recommend that they start at the bottom of the answer choices and that they work their way up to the top. So starting at answer choice E and working your way up to answer choice A. And the reason we recommend that is because, a lot of times we'll see students who start at the top, they'll see something they like, and then they'll go ahead and select that without going through all the answer choices. And so this way, it helps prevent you from making that mistake and biasing yourself. So that's kind of why we recommend starting at the bottom and working your way up to the top. Okay, so we'll go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Excellent. Thank you, Paris. So again, we've got the poll launched. Go ahead, take a look at those answer options. Hopefully you've already locked in on one or two choices. And let's see what you come up with. Again, we'll probably wait until about 2/3 of you have entered your selection, and then we will share those answers and dig into the correct, figuring out what is correct and why the others were incorrect. One thing we always note is that on test day, you want to make sure that you answer every question in that block. There's no penalty for wrong answers, so you don't want to leave any questions unanswered. Okay, so about 3/4 of you have voted. Interesting spread here. So let's close this poll and share the results. So interesting. The leading vote getter was option C, increased prothrombin time, with 36% of the vote, but 28% of you thought direct inhibition of thrombin was the correct answer. But even the other three all got double-digit responses. So interesting results here. So we're going to hide these, and we're going to go ahead and share the answer. And the answer is answer choice C, increased prothrombin time. So nice job. That was the leading vote getter. If you didn't get it right, that's okay. Paris is going to help you explain what was happening here. Paris?
Yes, absolutely. So this is a little bit of a tough question. So let's take a look at what's going on here. Okay. So if we take a look at the next slide, this patient is started on a medication because of atrial fibrillation. So we know maybe a blood thinner, right? Patients are often started on anticoagulants if they have AFib because they're at an increased risk of thrombi, or thrombosis. Okay. And one of the medications that patients can be started on is warfarin. Okay. Now, how do we know this is warfarin? How do we know this is warfarin and not another anticoagulant? Well, we're told that even though he started on a medication to prevent thrombi formation, so thinning out the blood, or an anticoagulant, he develops painful lesions as shown below. And what we're seeing there is necrosis of the skin. That is dark black necrosis with some blisters and bullae formation. Okay, and that's because the skin is dying. And that's because there's necrosis, and that necrosis is because there are thrombi in the skin, in the blood vessels of the skin. So even though he was started on an anticoagulant, he is in a procoagulant state within a few days. One of the medications we know that does that is warfarin. If we take a look at the next slide, this is our first aid table on warfarin. And you can see there, one, that warfarin, its main effect is on the extrinsic pathway, so it increases the prothrombin time. Okay. And if we look under that adverse effects row, that second sentence, there is an initial risk of hypercoagulation. Protein C, which is also inhibited by warfarin, has a shorter half-life than factors 2 and 10. So when you give warfarin, you deplete protein C, which is actually an anticoagulant, before you start getting rid of the clotting factors. As a result, you are initially in a hypercoagulable state. So patients can develop necrosis within the first few days. That's why a lot of times when patients are started on warfarin in the hospital, they're also they're bridged with heparin. So you were started on heparin in those first few days. So they're not in a hypercoagulable or procoagulable state with warfarin. So you bridge them with heparin. You wait until the warfarin has started to also deplete those clotting factors. You're checking their INR to make sure they are not hypercoagulable and they are now, their blood is nicely anticoagulated, and then you can stop heparin. Okay? But in this case, they didn't. We were not told that they bridged with heparin. He was just started on warfarin. So he's at an increased risk of hypercoagulation. So if we take a look at our question, we are told that the most likely medication, or we have now deduced that the most likely medication is warfarin. And we know that one of the characteristics of warfarin is increasing prothrombin time. Okay. Now the other answer choices are getting at other medications. A low platelet count, that would be getting at heparin. Okay. Heparin does not have an initial hypercoagulable state. Answer choice D is getting at TPA, tissue plasminogen activator. That is a thrombolytic used for the treatment of stroke, pulmonary embolism, things like that. Direct inhibition of thrombin, that is a mechanism of direct thrombin inhibitors. Those are not commonly used unless the patient has a history of HIT or heparin-induced thrombocytopenia, not what's going on here. Lastly, answer choice A, heparin may induce the development of IgG antibodies, increasing the risk of thrombosis, okay? But again, we are not told anything about thrombocytopenia, and so the best answer here would be warfarin, and that's by increased prothrombin time. Or I'm sorry, that's a characteristic of warfarin. So a tough question here, but let's see how we do with question number 2.
Yeah, very good. Thank you, Paris. Yeah, so a good one here to get your brain in gear. Obviously, a lot to take in, but just because it's step one doesn't mean that all of these questions are going to be one step. You've got to be able to think through this process. So let's see what we've got here in question number 2. So again, what we're going to do is we're going to start with the lead in. Let's see. Sorry, I had that little yellow dot there on the screen. So again, we're going to start with that lead in. Which of the following pathologic changes is most likely in this patient's muscles? So again, you can see the image there. Think about what kind of information you need to be analyzing as we read the vignette. A 57-year-old woman comes to the clinic because of a 2-week history of bilateral lower extremity weakness with ambulation and difficulty swallowing. Physical examination reveals the eye findings shown in the photo. Strength is 4 out of 5 in hip flexors and 4+ out of 5 in shoulder abduction. Serum studies show elevated creatine kinase and aldolase concentrations. So again, the question, which of the following pathologic changes is most likely in this patient's muscles? So I invite you to go back to the question box. Let us know how many steps you think this question is going to require in order to answer it as I pass it over to Paris.
Thank you, Jeff. So let's go ahead and let's take a look at this question now. So now we've got a 57-year-old woman. And this patient is coming in because of weakness in the lower extremities bilaterally when walking, and also difficulty swallowing. So a couple presenting signs and symptoms that can automatically really start to clue you in as to what you should be thinking about, or at least what category or chapter you want to start going down. Okay. They also give us a little bit of information about duration. So this has been going on for 2 weeks. Okay. So we know this isn't happening overnight, but it's still somewhat new. We're given a picture of some eye findings. We're given some physical exam and lab findings. So hopefully you guys all picked up on those and can really start to clue in as to what's going on. Now this question is asking us specifically about the pathologic change most likely in the muscles. Okay, so I think we've got a couple steps here. I think one, we've got to figure out what's going on in this patient, what's the condition, and then two, what pathologic change would we see in the muscles in that condition? So I think we've got a nice two-step question here. So let's go ahead and let's take a look at those answer choices. And once again, we're going to go ahead and start at the bottom and work our way up to the top. Answer choice E, perimesial inflammation with perivesicular atrophy. D, muscle atrophy with internalized nuclei. C, intracellular vacuoles with tubular or filamentous inclusions. B, endomesial infiltration of inflammatory infiltrate. And A, deficiency of dystrophin in the sarcolemmal membrane. So once again, we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Very good. Thank you, Paris. So the poll has been launched. Think about which of the following pathologic changes is most likely in that patient's muscles. Again, you got a number, got some steps to work through. Think about all of that information that you were gathering and what part of that information is going to be helpful in getting to an answer. Okay, looks like about half of you have voted. I'll give you a few more seconds to lock in your vote. Taking a peek at the poll in progress. Again, looks like we've got a couple of options that are garnering the lion's share of the vote, but no runaway favorite here. Okay, a couple more seconds and we're going to close the poll. Okay, poll has been closed. Let's go ahead and share the results. And it looks like answer choice E has the lead here, just kind of edging out answer choice B with A and D tied at 15%. So again, no clear-cut favorite here from the crowd. So let's go ahead and hide the results and go ahead and let's figure out what the answer is. And the answer to question 2 tonight is answer choice E, perimesial inflammation with perivesicular atrophy. So again, good job. The leading vote getter was the right answers, but obviously this is another tricky question. So I'm going to turn it over to Paris to help walk us through it.
Thank you, Jeff. Yes, nice job with this questions, but another tough question. So let's take a look at what's going on here. Okay. So we've got a patient with a characteristic rash on the eyes, and there's not a lot of things that at the step 1 level that can really cause this rash. It's kind of a characteristic rash called a heliotrope rash, where you get this erythema or even violaceous discoloration of the skin on the eyelids and around the eye. And this is pretty characteristic of dermatomyositis. Okay, it's one of the hallmark cutaneous manifestations of dermatomyositis that we see a lot in dermatology. Okay, on top of that, we know dermatomyositis is a disease that affects the muscles. So, not surprisingly, this patient has elevated muscle enzymes, elevated creatine kinase and aldolase. On top of that, this patient has muscle weakness, specifically in the proximal muscles, very consistent with dermatomyositis. hip flexors and shoulder abduction strength is decreased. On top of that, there is weakness on swallowing, dysphagia. There's also muscles in the whole tract that when we talk about esophageal and dysphagia, so you can get dysphagia and dermatomyositis as well. So all of this is kind of pointing to dermatomyositis, okay? So hopefully you guys picked up on that, okay? Now if we take a look at the next slide, what we'll see here is dermatomyositis and polymyositis. Polymyositis is another type of inflammatory myopathy, but you don't really get cutaneous involvement, okay? On top of that, if you were to do a muscle biopsy, you would see a little bit of difference between the two. Dermatomyositis has inflammation that's perimysial, while polymyositis has inflammation that's endomysial, okay? You can see there dermatomyositis specifically talks about perimysial inflammation and atrophy, okay? On top of that, you can see that on that second image, that heliotrope rash that that lady has. A little bit of violaceous discoloration of the eyelids, okay? All of these cutaneous manifestations are high yield, and they could show you one of those and expect you to kind of pick up on the clue that this is dermatomyositis, okay? If we take a look at the next slide, it'll be kind of even further looking into the presentation of some of those other myopathies, okay? So inclusion body myositis, you would expect to see specific inclusions or vacuoles. That's actually been, in the past, that's been an MSK question that we've asked before, okay? A deficiency of dystrophin is talking about Duchenne's muscular dystrophy, okay? And then muscle atrophy with numerous internalized nuclei, that's talking about myotonic dystrophy. Okay, so different types of muscle conditions. So let's go back to our question, the other answer choices. Hopefully you can see now why answer choice E is the best answer. Answer choice D, like we just talked about, is talking about myotonic dystrophy. C is talking about inclusion body myositis. B is talking about polymyositis, and A is talking about Duchenne's muscular dystrophy. So another good question here. So great job on this question.
Yeah, definitely. This is we've had a couple of tough ones to get us started here tonight, but you guys are faring valiantly. We're going to get ready for our next question. But first, just wanted to take a second to tell you a little bit about RX Coach. This is the tutoring service brought to you by the team that brings you first aid for the USMLE Step 1. There are a lot of different tutoring services out there. There are a lot of live review courses out there. We feel like this is the best option for students that are preparing for Step 1 or Step 2. And part of it is that we really ensure that the plan is tailored to your needs. So we start off with a 160 question assessment, and we then review that. We look at the areas where students might be struggling, areas where they may have some strengths, and then we personalize a study plan based on that, and also based on what the student feels they need to work on. I mean, the student, you guys know yourself better than anyone. So we feel like the quantitative and qualitative data will really allow our coaches to put you on the right track. We do use a one-on-one approach, and all of our tutors are RX certified, and they've been through they've been through the same things that you're going through now, and have a load of experience that they can draw from, as well as the tips and guidance that will help you succeed. And on top of that, you also get access to all of our tools, including RX 360 Plus, including all of our bricks. So if you find yourself in that spot right now where you're thinking, Step 1's coming up, I'm not ready, I could use somebody that will help me get on the right path, and that can help me stay accountable, let us know. You can go to rx-coach.com and set up a free consult. You can learn more about our program, and if it works out for you, if it meets your needs, then we'll go ahead and set you up with one of our incredible coaches like Paris and Brian. Okay, so let's go ahead and move to our next question of the night, question number 3. Again, we're going to do we do 4 questions each week. And I know that that's the one suggestion I hear in almost every survey. We should do more questions. We're just doing 4. We're gonna give it our best, and then we are going to have a raffle at the end of the evening. Again, you do need to be present in order to win. So let's go take a look at question number 3. Again, those answer choices are covered up, and we're going to start with the lead-in. Which of the following mechanisms best explains this neonate's most likely diagnosis? Okay, think about what kind of patient this is, what type of information you're going to be looking for as we read the vignette. A male neonate in distress is evaluated in the labor and delivery suite. On examination, he is pale and has a yellow-colored umbilical cord, skin, and eyes. His abdomen is distended with hepatosplenomegaly and generalized body wall edema. Laboratory results are as follows: hematocrit 24%, hemoglobin 4.9, reticulocyte count 24%, serum lactate dehydrogenase 4,500 units, blood group B Rh+. Now, again, which of the following mechanisms best explains this neonate's most likely diagnosis? How many steps do you think it will take to answer this question? Let us know there in the question box as I hand it over to Paris.
All right, let's take a look at this question. So now we're looking at a neonate, so a pediatric case. Okay, we're told that this is a male neonate, and right off the bat, they're telling us this neonate is in distress. Okay, the very first thing they're telling us is this neonate is in distress. Whenever you're told something right off the bat, whether it's they're in distress, something about their social history, like a 40-year-old male who drinks alcohol a lot, anything that is told to you right off the bat usually is an important clue that you want to make note of going into this question. Okay, and we can see here why that neonate is in distress. The patient has some abnormal physical exam findings, some very significantly abnormal lab result findings, and we were told at the very end kind of what this question is asking about. It's asking about a mechanism. Okay, and it's asking specifically about the mechanism that explains the diagnosis, the most likely diagnosis. So I think we've got a couple steps here. I think we've got to figure out what is the diagnosis, what's going on in this question, and then 2, what is the mechanism behind that diagnosis or that condition. Okay, so let's go ahead and let's take a look here at what we're working with in terms of answer choices. And so we've got some kind of in-depth, detailed answer choices. So whenever you see this, whenever you see answer choices like this, and on top of that, whenever you see questions where it's saying, maternal X attacking fetal Y or fetal X attacking maternal Y, you want to make sure that you're getting everything straight. Okay? You want to make sure that you have the right subject with the right noun. You want to make sure that you understand exactly which way things are going. Okay. So in this case, let's start at the bottom and make sure we're understanding that. Okay, so in this case, E, the fetus produced autoantibodies against his own erythrocytes. E, maternal leukocytes destroyed fetal erythrocytes. C, maternal erythrocytes sensitized the fetus to maternal B antigen. B, fetal erythrocytes sensitized the mother against Rh antigen. And A, anti-Rh IgG given to the mother hemolyzed fetal erythrocytes. Okay, so make sure you're reading those thoroughly. You're not getting mixed up here. Go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Very good. So thank you, Par. So the poll is open. Again, a lot of information to parse. We've got a lot of lab results to make sense of, and some lengthy answer options to synthesize here. So let's see how you guys do. We've got about a third of you have voted so far, so let's go ahead. Let's get in there and lock in those votes. Again, you never want to leave a question unanswered on test day. And even if you're not sure about it tonight, go ahead and take your best guess. No penalties here. We're here to learn. We're here to get better, and you are in good company. You've got well over 100 other comrades working to prepare for step one. So go ahead and take your best shot. Okay. Looks like over 70% of you have cast your vote. So I'm going to go ahead and close this poll. Poll is closed, and we're going to share those results. So in this case, the answer choice B has the lead. The fetal erythrocytes sensitize the mother against Rh antigens. And about almost a quarter of you thought that it's the answer choice D, with the maternal leukocytes destroying fetal erythrocytes. So let us hide the results and see what the answer is. And the answer is answer choice B. Fetal erythrocytes sensitize the mother against Rh antigen. You guys did it again. You picked the right answer. If you didn't get it right, that's okay. PARS is going to lead you to the right understanding. PARS?
Thank you, Jeff. Yes, also the leading answer here. So nice job, guys. But a tough question, and you know this concept is definitely a little bit tough. So let's see if we can try to explain it to you. Okay. So this newborn is anemic, right? Very low hemoglobin, is jaundiced, hepatosplenomegaly, right? This patient has a condition called hemolytic disease of the fetus and newborn. Okay. This patient has hemolysis. We know that the patient has low hemoglobin and also a very high reticulocyte count and also high LDH. So we know there's hemolysis going on. Okay. Now we know also that this patient has body wall edema and hepatosplenomegaly. So maybe this patient has hydrops fetalis. This neonate has hydrops fetalis. The one thing we're told is this neonate is Rh positive. Okay. So let's take a look at the next slide, talking about hemolytic disease of the fetus and newborn in first aid. This happens when you have an Rh positive fetus in an Rh negative mom, pregnant mom. Okay. And what ends up happening is in subsequent pregnancies, okay, not the first pregnancy. In the first pregnancy, the patient or the mom is exposed to fetal blood. And so they develop antibodies against that. Okay. In subsequent pregnancies, those antibodies then cross the placenta and attack the fetal red blood cells. Okay, that leads to hemolysis, breaking down of those RBCs. That leads to jaundice, anemia, high LDH, and hydrops fetalis. Okay, which is where you have an edematous fetus. Okay, and the way to prevent this is to give IgG to the Rh negative mom in the late pregnancy to prevent the mom from making that anti-D IgG antibody. Okay, so you want to prevent the mom from making those antibodies that would go across the placenta and attack the fetus. Okay, so let's go back to our question. So hopefully you guys can now see why answer choice B is the best answer. The fetal erythrocytes sensitize the mom against the Rh antigen. So the mom now is making antibodies that cross the placenta and attack the red blood cells. Okay. The other answer choices are incorrect. The fetus is not the one making autoantibodies against its own erythrocytes. Answer choice D, the leukocytes of the mom are not destroying the red blood cells of the fetus. It's actually antibodies, not leukocytes. Answer choice C is kind of the opposite. It's inverse. Again, make sure you're reading that correctly. It's the fetal erythrocytes sensitizing the mother. Okay. And then lastly, answer choice A, that's actually talking about ROGAM. That actually would prevent this condition from happening. So in this case, fetal red blood cells sensitize the mom against that antigen, and in subsequent pregnancies like this one, the mom now has antibodies that can attack the fetal red blood cells, and that can lead to this condition. Okay, so great job with this question as well. Let's move on to that last question of the night.
Okay, thank you, Paris. Again, good job, everybody. Let's go ahead and see if we can finish strong. This is our final question of the night. We will have a raffle after we go through the explanation here. So let's all do our best as we open up our final item. Again, we've got all of those answer options covered up, and we're going to start with that lead-in. Which of the following complications is most likely in this patient? Okay, so you know that there's something going on here, so let's go and see if we can figure it out. A 53-year-old man with alcohol use disorder presents to the emergency department with complaints of nausea, vomiting, and severe epigastric abdominal pain for the past 3 hours. The pain radiates to his upper back and left shoulder, and he experiences mild relief when leaning forward. Temperature is 38.4, lipase is 325, which has a normal range of 0 to 50. So again, which of the following complications is most likely in this patient? Think about how many steps this might require. You can go ahead and register your vote there in the question box as I pass it over to Paris.
Thank you, Jeff. So now we are on our last question of the day. So hopefully you guys are starting to get a sense of, what we think are those important clues in the vignette and the lead-in, so you really can start to answer these pathology questions as best as you can. Okay. Now in this case, interestingly enough, this is kind of exactly what I was talking about earlier. We're told this is a 53-year-old man, and right off the bat, they're telling us that he's got alcohol use disorder. Okay. So obviously a very important clue, might even very high likelihood that could be playing a role in this question. Okay. Now they tell us why he's coming in: nausea, vomiting, and abdominal pain. They also tell us it's very acute, 3 hours. Okay. Now whenever you have abdominal pain, you always want to see, where does it radiate to? What makes it better? What makes it worse? How are they doing in terms of their vital signs? Are there any abnormal lab findings that can clue you in as to what's causing that abdominal pain? In this case, there are a couple things. Okay. And then they're asking us about a most likely complication in this patient. So I think we've got a couple steps here. I think one, we've got to figure out what's going on in this question, what's the most likely diagnosis, etc. And then two, what is a complication that could occur most likely in this patient? So nice two-step question here. So let's go ahead and let's take a look at those answer choices. Once again, we're going to start at the bottom and work our way up to the top. Answer choice E, proteinuria. D, polyuria with dilute urine and hypernatremia. C, peaked T waves on ECG. B, muscle twitching after palpation of the cheek. And A, flank and groin pain with hematuria. So we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Okay, this is your final question of the evening. or perhaps the morning, depending on where you're tuning in tonight or tomorrow. So go ahead and take your best shot here. We've so far we've had three pretty tough questions, but you guys have homed in on the correct option on each one. So let's see if we're gonna keep that streak alive with question number 4. Looks like about a third of you have voted. Let's go ahead, everybody, lock in your answer. We've got one option that is getting to run away with it a little bit. I don't know. It's we'll see if it comes back down to earth here in a minute. And again, we'll after we go through this question, we'll have our raffle for tonight. Okay, let's see. So we've let's see, about 2/3 of you voted. I'll give you just a couple more seconds, and then I'm going to go and close the poll. Okay, the poll's been closed, and let's share the results. So early on in the voting, almost half of you were leaning towards option B, muscle twitching after palpation of the cheek, and then the numbers kind of creep down a little bit. It's still the overwhelming favorite, but almost a little over a fifth of you thought that it's peak T waves on ECG. So let's go ahead and we'll hide those results and open up the correct answer. And the correct answer is answer choice B, muscle twitching after palpation of the cheek. Congratulations to the whole crowd. You guys, you got the right answer on everyone tonight. Now, again, that's only a little over a third of you got this one right, but the main thing is you're learning with each question. So I'm going to pass it over to Paris to help break this one down for you. Paris.
Oh, sorry, I was muted there. Let's take a look. Thank you, Jeff. Let's take a look at what's going on here. Okay. So if we take a look at this vignette, we see that this patient might have classic signs and symptoms of pancreatitis. Pain radiating to the back, epigastric abdominal pain, history of alcohol use, and most importantly, elevated lipase. Okay. Now, if we take a look at our slide on pancreatitis and our table in first aid, we can see there, one, that one of the causes is ethanol. Okay, so one of the causes of pancreatitis is ethanol. Right off the bat, they told us this patient was had alcohol use disorder. Okay. We also see there that some of the diagnostic criteria, epigastric pain radiating to the back, increased serum lipase, all things our patient had. And then if we take a look at those complications, remember, pancreatitis complications are very high yield. Okay, they love to ask about these. You can see there, the last complication listed is hypocalcemia. And that's because the calcium likes to deposit and precipitate in that inflamed pancreas. So you actually lose a little bit of that from the blood. You kind of become hypocalcemic. Okay. Now, if we take a look at the next slide, this is our nice table in first aid talking about electrolyte disturbances. So we take that hypocalcemia, and now let's look at what it would look like in our electrolyte disturbances table in first aid. Okay. And you can see here, low serum calcium can lead to twitching, or the Chvostek sign. I apologize if I'm not pronouncing that right, but that is basically a sign where if you tap the facial muscle or palpate the cheek, you can see muscle twitching. Okay, those are some of the signs of low calcium. So hopefully now you guys can see how we got to that. One, needed to figure out this is pancreatitis. Two, the complication. And three, they kind of added in another step in the answer choices. Okay, so let's take a look at the other answer choices and see maybe what that was getting at. So proteinuria, kind of a red herring here, not too much to going on there. Polyuria with dilute urine, that's actually seen with hypercalcemia, not hypocalcemia. Peaked T waves, that's associated with hyperkalemia. Okay, so potassium, not what's going on here. And lastly, answer choice A, flank groin pain with hematuria, that's seen in nephrolithiasis, which could maybe suggest hypercalcemia, not hypocalcemia. So again, a good question here that required getting a few steps correct on the way, but hopefully you guys are able to pick up on the best way to approach some of these pathology questions. And I will pass it back to you, Jeff.
Excellent. Yeah, thank you, Paris. Yeah, this is we've had a good set of path questions tonight, and hopefully you picked up some tips along the way, not only in what things that you should be keying in on, high yield elements, things that you're likely to see on test day, but also ways in which you can analyze and dissect these questions. So, good job, everybody. This is a good session and a good overall collective effort by the group. So. If you are wondering, gosh, I'd like to take a look at these questions again, go ahead and take a screenshot here, grab these QIDs. What you can do is in USMLE-Rx, you can go to the Rx search section, and you can actually search by QID. So feel free to grab these and do some further review.